Hi friends, my name is Dr. Karan Choudhry and I am working in ASUTOSH Hospital, Surat as an associate orthopedic surgeon. Right now we are going to discuss a case of an accessory navicular that was treated with a Kidner's procedure. In the case of accessory navicular, we also need to assess the symptoms, the deformity of the patient. Each patient needs to be individually assessed in detail. The deformity is taken into consideration. Also, whether he's able to stand on one heel, that is the single heel raise test that we see for posterior tibial tendon deficiency. So we basically get an idea of the anatomy of the posterior tibial tendon and the relationship to the surrounding structure. Also, if the tendon is degenerated or synovitic, we get an idea. We see for the too many toes sign, which if present is indicative of a heel valgus. In that case, we need to deal with the deformity in the calcaneum by doing an osteotomy. We also see for the mobility of the talonavicular and calcaneocuboid joint. So we know whether it is rigid or whether it is flexible. We get a weight bearing x-rays of the patient, which is also quite indicative of the relationship of different bones of the foot with each other. Yeah, so coming to the live surgery that we are performing in our OT, this is a Kidner's procedure with a posterior tibial tendon advancement. We are marking the incision. We can see the medial malleolus being marked with betadine, and the arc of the foot is being marked right now with a mosquito. The point that we can see is the navicular. So basically our incision would be in line with the arc of the foot the patient has. We are incising through the skin, and we do not encounter much of subcutaneous fat. We enter into the deep fascia, but before that there are some communicating branches of the saphenous system that we need to uh, coagulate with a cautery before proceeding towards the posterior tibial tendon, because they have a tendency to bleed if not well coagulated. So so we are now basically coagulating these vessels, and further like with a paintbrush like manner we are extending our incision further into the posterior tibial tendon sheath. We can see one bleeder that is in the proximal region of the incision, and we plan to preserve that vessel. It's a communicating branch that we plan to preserve, and we are the coagulating the remainder veins that we can see the branches. Now we'll try to isolate this vessel and hold it back into the retractor. However, this is by choice. There's no hard and fast rule as to coagulation. We are now dissecting into the tendon sheath. We are holding back this venous structure into the retractor. So we have made a nick into the posterior tibial tendon sheath, and basically extending with a scissor proximally, and then we would be going distally. So thereby we will be just splitting the tendon sheath to reach the posterior tibial tendon with a knife. So basically the question that comes up as to what is the concept of arc correction with this surgery. The amount of arc correction depends upon the deformity present. If the deformity is severe, alone Kidner's procedure with posterior tibial tendon advancement would not benefit. However, if the deformity is limited and the patient has complaints of only the bump deformity, so this surgery helps. Now we are splitting the posterior tibial tendon into a smaller dorsal portion of the tendon, and the remainder we would be splitting it distally. over the plantar surface. We are splitting the dorsal surface tendon. The tendon is attached to the navicular bone by strong Sharpie fibers, and so it is a bit difficult to erase it with a knife too. However, we just split it enough to isolate the medial portion of the accessory navicular and a bit of the navicular that is seen as a bump. So coming back to what the patient expects from the surgery, or what as a orthopedic surgeon we need to explain to the patient. Basically, with respect to deformity, there is a good deformity correction in this surgery, so a patient can expect that the bump that is present preoperatively will go away. But with respect to arc correction is actually not expected. We have to really evaluate the patient before explaining the arc correction component. Right now we are dissecting through the lower or the plantar aspect of the posterior tibial tendon, basically to isolate the accessory navicular portion.
ઇન્ટિરિયરલી જરૂર હોય એટલે મેં આ ફર્સ્ટ ટાઈમ જોયું કે ટેન્ડન સ્પ્લિટ કરી જવાનું. આઈ
All
ઓલવેઝ
around.
પુટ ધ ટેન્ડન ઇન્ફિરિયરલી ઉપરથી જવાનું ટ્રાય કરતો.
આ છે ને આ મીડિયલ લોંગિટ્યુડિનલ લિગામેન્ટ આવે.
લાઇટ ફોકસ કરો પ્લીઝ. લેફ્ટ શોલ્ડર. And now with the help of a small osteotome, we are going all around the accessory navicular portion that we can see. With the help of a osteotome, we are gently dissecting out the accessory navicular from its surrounding normal structures that we can see, the normal navicular.
जॉइंट आएगा और पूरा का पूरा एक्सरसाइज करेंगे.
So we are basically enucleating the deformity or the accessory navicular that we can see. And then removing the deformity portion. With the help of a blade, we are isolating the posterior, the deformity, basically cutting through the whatever is left over. There are many questions that have been asked as to whether to do a lateral column, what to do about the lateral column. If there is a flat foot with a severe deformity, then an Evans procedure is required for lateral column lengthening. But if there is no flattening of the foot and the patient has just unilateral symptoms, being the bump being the most prominent symptom of the patient, so then we just do a Kidner's procedure. We just remove the accessory navicular portion, remove the deformity, and the posterior tibial advancement is being performed. With the help of a nibbler right now, we are removing the deformity that we can see right now.
Next step. Okay.
And with digital palpation, the remainder roughened surface is being palpated. And now we plan to remove. Now we scrape a bit of the first metatarsal so as to check the level of the navicular portion that exceeds over the metatarsal. We isolate the extra navicular that is seen. Probably many people would just leave the remaining navicular. However, the deformity tends to persist if there is a failure of
एकदम straight line.
removal of navicular. So patient may complain after the surgery with respect to it. With the nibbler and cockers, the deformity is removed.
अब ये देखिए तो लाइन में आ गई, फिर उसके बाद
So basically, with the help of the removal of navicular, we have to make it into the level of the remainder of the foot. Right now we are removing it with the nibbler bone pieces.
पहले मैं क्या करता था, वो बम्प रहने देता था, एक्सेसरी एक्सरसाइज करता था. Rust. अच्छी से था कि पेशेंट को क्या ठीक करो तो देवो न देवो अच्छा.
मैं तो सर एक पेशेंट में तो
With the help of the rasp, we are smoothening the roughened edges so that it may not cause pain later. And then later we digitally palpate to see if the roughened edges are removed.
You have to always tell them, arch नहीं आवे.
हाँ
Pain
करेंगे
just
जैसे
sit. Pain just sit. I would expect pain to go with almost completely.
आर्च नहीं जाएगा मतलब
The arc of
Explainers जो रहता है ना,
medial
arch नहीं होता है.
medial arc जो रहता है ना वो नहीं.
ये लांजी
The posterior tibial tendon is now being
75%.
क्या arch की
नहीं,
pain?
इसका-
cut
इसका
dorsally
success rate
to isolate it from
Pain,
the navicular.
85,
Ideally it should go.
85, 90.
फ्लैट फुट
Somewhere I went wrong.
The remaining metatarsal insertions are not being handled, only the navicular. We check into the C-arm whether the level of the navicular is in line with the rest of the foot, that is the metatarsal and the cuneiforms. So we could see that the level was quite okay, in line with the other the arc of the foot. So we had basically accepted whatever we have removed, and now we are making space to basically reroute the posterior tibial tendon into the navicular, so that it gives an advantage of the basically to maintain the arc as well as to lift up the foot whenever it is required. The patient that usually had the pain previously of due to mechanical strain of the posterior tibial tendon abnormal attachment would now disappear. Now there is a drill hole being drilled from the inferior surface of the foot into the navicular and then palpated with the finger over the dorsal surface. Another drill hole is planned to be made into the anterior portion of the navicular, so that the posterior tibial tendon would be planned to be rerouted into that canal that is going to be drilled right now. You can see the inferior cortex of the navicular being drilled with a drill. We need to take care to prevent the splinters that are occurring into the navicular. People may just keep the accessory navicular and use it to make drill holes into the navicular. However, the mechanical strain would still persist after the surgery. So it is a difficult thing right now to drill into the holes. We are extending the hole into the superior surface to connect to the distal hole. So as to make a communication to pass our Proline. We use a 1 number proline, a 10 proline, to tie the posterior tibial tendon. We can feel for the communication from the superior surface of the tunnel. We're drilling our tunnels. We have to take precautions as to prevent splintering of the navicular, because in that case we would land up in a very difficult situation. We must take our own time to drill these holes. We have passed an 80 number needle through the superior surface of the second hole, and through this we are going to pass our, through the needle we are going to pass the proline 10 into the superior surface. Many people do ask as to what are the results of the surgery, or what should the patient expect. Probably the pain relief should go away after the surgery. Arc of the foot may not be completely relieved. This is a rewarding surgery provided the indications of the surgery are followed. We have taken a bite of the suture material into the dorsal of the plantar surface of the posterior tibial tendon, and a reverse bite again into the tendon. We have clamped the other end with a mosquito. So now we have decided to take another bite and probably another reverse bite. And then we would finally pass the suture material into the first hole. Now the K-wire that we see, we have decided to remove the K-wire. So with very gentle movement, we are removing the K-wire. And we are now isolating the superior surface. We are re-drilling the superior surface, so to connect the inferior portion of the tunnel. We would be passing this 80 number needle into the tunnel. And then we have passed the suture material into the tunnel, removed the needle, and now we are tying the construct into the knot that is on the superior surface. In this time, portion of the time, we have to maintain the arc of the foot as much as possible into the cavovarus foot to restore the arc. So placing the foot into an appropriate position of a cavovarus. We have now decided to tenodis the posterior tibial tendon, basically to shorten it for bringing it into tension. So basically we are tensioning the posterior tibial tendon by taking a single knot right now. We need to use proline suture material with caution because it has a tendency to cause a lot of irritation below the skin of the patient. The knot that we have taken is before we have actually tightened up the superior knot of the two suture materials. We have taken another suture material basically to give a tension in the posterior tibial tendon, and right now we have planned to take another knot in the distal portion of the posterior tibial tendon, plantar surface, and this would also be expected to serve the same purpose of giving tension. So having applied both of these knots, we are going to tighten the superior knot. So basically, depending on the preference of the surgeon, he needs to decide as to how many knots have to be applied. We have decided to knot it 5 times. So having done this, we are done with the majority portion of the surgery. Now we are closing the deep fascia with Vicryl 10.
आप जितने भी एक्सेसरी navicular आते सबको एडवाइस कर
किसी को नहीं,
क्यों सर?
पहले उसको फिजियोथेरेपी
And then we would be closing the skin in a subcuticular manner.
नीडल आर्क सपोर्ट, एनेसिड, फिजियोथेरेपी, फिर वो अगर मेरे को से दुखी होकर भाग जाए तो मैं पार्टी खाता हूँ।
We apply a small dressing over the localized incision portion and give a cast that we remove after 6 to 8 weeks. This cast is applied in cavovarus position. The cast is not removed unless there is very severe bleeding or any neurological deficit or neurovascular compromise. So that is the venous structure that we had preserved, that we can see distally right now in the video. After 6 to 8 weeks, we make the patient walk for 1 month partial weight bearing, and following that patient is allowed to bear full weight.
તમે લોકો કરો છો
So this is the position of the cast that is being applied.